morning all. Today's our topic is continuation of the cranial cavity and the topic is cavernous sinus. Here the tributaries or incoming channel from the orbit, the superior ophthalmic vein, the branch of the inferior ophthalmic vein, the cranial vein of the retina may drain either into the superior ophthalmic vein. The from the brain has a superior medial cerebral vein, inferior cerebral venous from the temporal lobe, the front from the meninges, the sphenoparietal sinus, the frontal trunk of the middle meningeal vein may drain either into the pterygoid plexus and draining channel of the communications. Here the figure of the side view of the tributaries and communications of the removal sinus. Here the second figure is superior view of the tributaries of the communications into the cavernous sinus. Here the continuation of during the channel of the communications into the transverse sinus through the superior petrosal sinus and into the internal jugular vein through the inferior petrosal sinus and into the pterygoid plexus of the venous through the imaginary vein passing through the foramen ovale. The intro to the facial vein through the superior ophthalmic vein. The right and left cavernous sinuses communicates with each other and through the anterior posterior intracavernous sinus. The factors helping expulsive of blood from the sinus, the expulsive pulsation of the internal carotid artery, gravity, positions of the head. Now here the clinical anatomy. Thrombosis of the cavernous sinus may be caused by sepsis into the dangerous area of the face and nasal cavity and paranasal air sinuses. The nervous symptoms, severe pain in the eyes and forehead into the area and distributing of the ophthalmic nerve. Involvement of the third, fourth and sixth cranial nerve resulting in the paralysis of the muscle supply. Venous symptoms marked edema of the eyelids, cornea and the root of the nose and exhalmes due to the congestions of the orbital vein. Communications between the cavernous sinus and the internal carotid artery may be produce the head injury. The superior sagittal sinus. The superior sagittal sinus, occipital upper convex attached margins of the flex cerebri. It begins entirely at the crista by the union of the tiny meningeal vein. Here it is communicated with the venous and frontal sinus of the occasionally with the venous of the nose and through the foramen cecum. The section it ends near the external occipital protuberance by the turning to the side. Usually the right end becomes a continuation with the right transverse sinus. The junction of all these sinuses is called confluence of the sinuses. The interior of the sinus shows opening of the superior cerebral veins, opening of the venous lacunae, usually 3 on each side, and arachnoid villi and granulations projecting into the lacunae as well as into the sinuses. Numerous fibrous bands crossing the inferior angle of the sinus, and here the tributaries, the superior sagittal sinus receives these tributaries superior cerebral veins which now open into the venous lacunae and parietal imaginary vein. Venous lacunae usually 3 or each side which first receives the dipolic and meningeal veins. Occasionally a vein from the nose opens into the sinus when the foramen cecum is patent. Now clinical anatomy. Thrombosis of the superior sagittal sinus may be caused by the spread on infections from the nose, scalp and the dipoli. A considerable rise in the intracranial tension due to the divergent absorption of the CSF. The delivery delirium and the sometimes cavernous due to the congestion of the superior cerebral sinus and paraplegia of the upper motor neuron types due to bilateral intra involvement of the paracentral lobules of the cerebrum and inferior sagittal sinus. The inferior sagittal sinus, a small channel, lies in the posterior two-thirds of the lower and concave free margin of the cerebri. Now, sagittal sinus, the straight sinus, lies in the median plane within the junctions of the flex cerebri and the tentorium cerebri. It is formed anteriorly by the union of the inferior sagittal sinus with the great cerebral vein. Here the figure of the scheme 2 shows the intracranial venous sinus, lateral view. Here the figure of the coronal sections through superior sagittal sinus showing the arrangement of the meninges. Uh, the transverse sinus. The transverse sinus are large sinus. The right sinus usually larger than the head. Left, it situated in the posterior part of the attached margin of the tentorium cerebri. And the right transverse sinus is usually continuation of the superior sagittal sinus, and the left sinuses are continuations of the straight sinuses. Here tributaries are superior petrogenial sinus and inferior cerebral venous. Here the sigmoidal, here the inferior cerebral venous, diapolic veins, and the inferior anastomosis vein and sigmoidal sinus. Each sinus, right or left, is the direct continuation of the transverse sinus. It is S-shaped, hence the name. It extends from the postero-inferior angle of the parietal bone to the posterior part of the jugular foramen, where it becomes the superior bulb of the internal jugular vein. It grooves the mastoid part of the temporal bone. It is separated anteriorly from the mastoid antrum and the mastoid air cells by only a thin plate of bone. The mastoid and condylar imagery vein, cerebral veins, and the internal auditory vein. Now here the clinical anatomy. The thrombosis of the sigmoidal sinus is always secondary to infections in the middle ear or otitis media or in the mastoid process and called mastoiditis. During operation on the mastoid process on one side one should be careful about the sigmoid sinus and it is not exposed. Spread of the infection or thrombosis from the sigmoid and the transverse sinuses to the superior sagittal sinuses may cause repair and CFC drainage into the lateral or maybe therefore lead to the development of the hydrocephalus. Other sinuses, the occipital sinus is small and lies in the attached margin of the flex cerebri. The sphenosagital sinuses, right and left, lies along the posterior free margin of the lesser wing of the sphenoid bone and drain into the anterior part of the cavernous sinus. The superior petrogenial sinus lies in the anterior part of the attached margin of the tentorium cerebri along the upper border of the petrous temporal bone. The inferior petrogenial sinuses, right and left, lie in the corresponding petrooccipital fissure. The basilar plexus of veins lies in the clevus of the skull and it connects to the two inferior petrogenial sinus and communicate with the internal vertebral venous plexus. The middle meningeal veins from the two margins, trunks and front and the interior and petrogenial posterior, and which is the front trunk and maybe the parietal trunk usually ends in the pterygoid plexus through the foramen spinosum. The anterior and the posterior intracavernous sinus connects to the cavernous sinus. Here the imagery vein valveless and communicates with the intercranial with the extracranial veins. Here the sinuses and connection of the veins. Here the hypophysis cerebri, pituitary gland. Introduction. The hypophysis cerebri is the small endocrine gland situated in the related to the base of the brain. The gland lies in the hypoglossal fossa, hypophyseal fossa, or the sella turcica or the pituitary fossa. The fossa is roofed by the diaphragm celli. Here the figure of the part of the hypophysis cerebri of the sagittal section. Now, the gland is oval in the shape and the measure of 8 mm and posteriorly and 12 mm in the transversely. Its weight is about 500 milligrams. Relations. Superiorly, diaphragm, celli, optic chiasma, and tuberosinium infundibular recess of the third ventricle. Inferiorly, irregular venous channel between the two layers, hypoglossal fossa, sphenoidal sinus on each side, the cavernous sinus with the contents. Subdivision. The parts of development. The gland has two parts, adenohypophysis and the neurohypophysis, which differ from each other and embryologically. And adenohypophysis anterior lobe or the anterior parts dilates or parts of the granulars, and anterior lobes are part of the intermediate, and the tubular lobes or the parts tubulars. The neurohypophysis the posterior lobe or neural lobe or parts posteriorly in fundibular stems and median emissions of the tuberculous. Here the arteries supply the hypophysis cerebri supplied by the following branches: one superior hypophyseal artery, the inferior hypophyseal artery, and its branches ventral, upper, and lower part of the artery. Is inferior hypoglossal artery divided into medial and lateral branches, and which join the another from the arterial rings. The anterior lobes or the pars dilates are supplied exclusively by the portal vessels arising from the capillary tubes. The venous drainage short vein emerges into the surface of the glands and drain into the neighboring dural venous sinuses. Here the figure of the artery supply of the hypophysis cerebri. Now hormones, anterior lobes. There is the adenohypophysis alpha cells, chemophysis cells 50%, 43%. Memo is secrete the growth hormone, and the memory secretes the lactogenous hormones, and cardiovascular secretes the ACTH. Basophil 7 cells, it is secrete the TSH, secrete the FSH, secrete the LH and SCH. And common cells is 50% present in non-secretory phases and has cells types. Intermediate lobes, the in the made of the numerous basophil cells. Posterior lobe is a large number of the non-myelinated fibers and modified triangles, and hypothalamus and thalamus. The hypophyseal tracts being in the preoptic paravertebral nucleus in the hypothalamus. There is a vasopressin ADH which is acting in the kidney tubulus, and oxytocins which is the promote contractions of the uterine and the mammary smooth muscle. Now clinical anatomy. Pituitary gland tumors gives rise to the two main categories. General symptoms due to the pressure over surrounding structures. The cellular tertiary enlarge in the side of pressure around the central part of the optic chiasma, and the pressure over the hypothalamus over the causes on the hypothalamic syndrome, and the large tumor of mepasis open the third ventricles, and specific symptoms depending on the cell types of tumors, and acidophils, eosinophils edema causes, and basophils edema causes Cushing syndrome, and uh, chromophobe adrenal causes effect of the hypopituitarism, and the posterior lobe damage causes diabetes insipidus, and through the lesions is the causes of lice, and this is a figure of beta pots.